Well, good day, everybody. My name is Dr. Howard Shaps. I am the Medical Director for Healthcare Excel, and today we're going to be talking about Clostridium difficile infections, and we're going to try to make our hospitals safe from Clostridium difficile infections. So I'm going to give you a brief overview, and then we're going to go into some preventive as well as some other methodology we can use to hopefully decrease the amounts of infections we see from C. difficile. But C. diff, or C. difficile infection, commonly cause a mild to moderate diarrhea. However, it can sometimes lead to a fatal colitis. It's one of the most common nosocomial infections, and we've seen that it affects approximately 20% of individuals who are hospitalized. Not everyone is symptomatic. About 30% of patients will develop diarrhea after they become infected with C. difficile. So once a patient in a hospital setting develops diarrhea, the diagnosis needs to be entertained, especially in those who have received antibiotics within the previous 2 months. That can occur outside the hospital setting as well. However, if diarrhea occurs 72 hours or more after hospitalization, it's very well possible that the patient could be infected with the C. difficile bacterium. Here are some facts. 2 to 3% of healthy individuals actually carry C. difficile with them, and 70% of infants carry it as well. Colonization or infection occurs by the fecal-oral route, and C. difficile produces heat-resistant spores that can persist, believe it or not, for months to even years. And infections occur in healthcare facilities when contamination with spores is prevalent. In addition, when patients start taking antibiotics, they can suppress the gut flora, which allows the C. difficile bacterium to proliferate. C. difficile lives in the large intestine or the colon. From an epidemiologic standpoint, C. difficile infections occur not primarily, but quite often in a hospitalized patient. And we see up to 3 million cases per year. And the incidence has been increasing throughout the 90s as well as in the 2000s. Back in the 90s, it was reported about 30 to 40 cases per 100,000. And documented in 1985, they saw approximately 84 patients per 100,000. The C. difficile discharge diagnosis increased dramatically from 2000 to 2009, from 139,000 cases to 336,000 cases. In 2010, 94% of cases were associated with receiving health care, and 75%, believe it or not, were actually not hospitalized. So it can occur in the community as well. Some morbidity mortality facts. In those who are elderly and frail, C. diff can cause a 25% mortality rate. And those with a serious condition, up to 10 to 30%, can suffer a fatal disease. The Centers for Disease Control and Prevention, or the CDC, found that in 2007, 14,500 deaths occurred due to C. diff, which was up from 2,700 in 1999. And the average length of stay for those who are infected with Clostridium difficile, we believe, increases from about 5 days to those who do not have the diagnosis, up to 13 days for those that do. And most recently, there's been some outbreaks that are associated with pretty virulent strains of the organism. So what are some risk factors for C. difficile? Well, number one, antibiotic use. Even brief exposures to antibiotics put people at risk for having the C. diff infection. As we get older, it becomes a risk factor. Room sharing in a hospital, in the ICU, can cause our risk factors for C. diff infection, and a prolonged stay in the hospital makes patients more at risk as well. And there's some lesser known risk factors as well. These include proton pump inhibitors, those who have certain cancers, inflammatory bowel disease, and then some non-surgical GI procedures are associated with acquiring the infection. There are certain conditions that are also associated with infection from C. difficile. So patients that are dehydrated, those with electrolyte disorders, those who are already bacteremic, as well as those with some kidney issues, are also associated with C. difficile infections. So prevention is key, and the more we can prevent the organism from recurring, we're going to decrease our morbidity and we're going to decrease our mortality. So promotion of disposable gloves, laboratory coats, and proper hand washing techniques are very, very key. Education to the medical staff, nursing staff, as well as all members of the hospital is very, very important as well. The mode of hospital transmission is not exactly clear, but it's believed that spores will survive on countertops, on desktops, on chairs for a long time. So the better the cleaning methods are, the less chance of acquiring disease. Isolating patients is recommended. Sometimes it's impractical. However, the more you can isolate a patient with possible C. difficile, the better off the hospital is going to be. And then, when you have severe epidemics, aggressive control measures such as treatment of asymptomatic carriers may be needed as well. And we touched on this a few minutes ago. However, antibiotic use and decreasing antibiotic use is key. And this is probably the most important preventive measure that's out there. And the CDC highly recommends improving the use of antibiotics, whether it's decreasing antibiotic use or using the right antibiotics when needed. And when patients are on antibiotics, it increases their chance of acquiring the C. difficile infection by 7 to 10 times while the patient's taking the antibiotic for a month, even after discontinuation. And then patients are still at threefold risk for up to 2 more months after taking the antibiotic. So the effects of antibiotic use is very, very important. Hand hygiene is also extremely important, and soap and water has been shown to be more effective than using the alcohol rubs. One hospital study showed that even though they increased hand alcohol rubs, there was no increase in the C. difficile rates. So even though some of the studies have been a little conflicting, discouraging alcohol gel use may actually undermine hygiene programs in general. So whether or not to prevent doctors, clinicians, nurses from using the hand rubs probably wouldn't be a great idea. However, soap and water is very, very key to preventing C. diff from occurring. So from a hand hygiene standpoint, spores may be difficult to remove from hands even with the hand washing. So again, using gloves, using contact precautions is key to preventing the transmission of C. diff from healthcare workers. And when we talk about environmental cleaning, bleach is the most talked about method as to killing the spores, where standard disinfectants cannot. There's limited data that cleaning with bleach will reduce C. difficile transmission, but it's highly recommended from the literature that I've gone through. There have been some before and after studies that have shown that using bleach cleaning will help in those in high endemic areas. So again, bleach is probably the key method to decreasing the number of spores and decreasing the rate of transmission of C. difficile. And here's a picture of a spore, an electron microscopic view, and it just shows you what they look like up front and personal. So here's some isolation considerations. Patients with C. diff can contaminate the environment in the hands of healthcare personnel, even when while they're waiting for results of diagnostic tests. So when taking isolation into consideration, those that have more than 3 unformed stools within 24 hours, and when you talk about unformed stools, stool that take the shape of the container, those that have this type of stool need to have the stool sent for testing, and it being probably the hospital's best interest or the clinic's best interest to isolate the patients pending the results of the testing. The positive predictive value of testing will be optimized and focused on patients that have 3 unformed stools within a 24-hour period, and that's probably the best patients to test. The one exception to this is those that have a possible recurrence. At that point, those patients can be considered for isolation. and testing even after the first unformed stool. So if the patient doesn't have prior antibiotic use and does not have one GI infection, the chances of missing a C. diff infection by not testing them is quite low. So the Society of Healthcare Epidemiology in America, or SHEA, recommends against testing asymptomatic patients, including those who are asymptomatic even after treatment. So diagnostic testing is not meant for everybody. Again, to talk about what we mentioned a few minutes ago, only those with liquid or unformed stools should be tested. And there are a few exceptions, as we talked about a few minutes ago, but if we're investigating from an epidemiologic standpoint, diagnostic testing can occur. And in those that have an ileus, if we can get a stool sample, it would be helpful as well. These patients will have C. diff, and possibly even without overt diarrhea. They'll have fever, abdominal pain, a high white blood cell count. They can even perforate their bowel. So these patients that are suspected should probably be tested as well. From a diagnostic testing standpoint, it doesn't help to give multiple submissions. And there are 3 studies that have all come out within the last decade or two that have shown that if you increase your submissions, the chances of finding the C. difficile bacterium or the toxin is relatively low. So again, repeat testing probably isn't needed. One test should be sufficient. And when you're testing for C. difficile, we're testing for the toxin. Cultures can be done, but they're not practical, and they take a while for them to process and become positive. And by the time they become positive, complications can occur. So again, testing for the toxin is more important than anything else. The bacteria produces toxin A, toxin B, and a binary toxin, and all tests should contain a minimum a toxin B detection component. So as we were talking about toxin detection, one last method of detecting C. difficile toxin in the stool is by using PCR, or polymerase chain reaction. This is the most recent testing modality that's out there. Stool is tested for the C. diff toxin using the PCR assay, and allows for a rapid detection of the toxin. And those who may need to be isolated, it will allow the isolation either to occur very quickly, or if the test is negative, may not require those patients to be isolated. And when the test has become positive, it allows for much more rapid treatment of those patients who are infected with C. difficile. However, negative test does not rule out C. diff infection, or CDI, because those patients may have the bacterium without producing the toxin, or the toxin may not be produced in a high enough quantity for the assay to become positive. So there are some non-standard treatment and prevention methods for those who have multiple recurrences. None of all of these have been proven to work, although these are all been reported in the literature. Probiotics with Saccharomyces species increases patients' risk for fungemia and its related complications, and it probably is not the best idea. C. difficile immune whey is well tolerated, and it has been shown to be similar to the use of metronidazole or flagyl for treating recurrent C. diff. Then fecal flora reconstitution, although not done very often, has been shown to prevent infections for up to a year. Some other non-standard treatment regimens, probiotics, prebiotics, toxin-neutralizing antibiotics alone do not reduce primary hospital C. diff infections incident rates. However, when a oligofructose prebiotic or toxin-neutralizing antibiotics were used, it showed that it's helped a little bit. So whether these work or not, there's been some reports in the literature that they can be helpful. So when you have a patient with suspected C. diff, there are certain points that need to be discussed. Risk factors need to be discussed. If you're talking about a family member that cares for a patient, it needs to be discussed how they can prevent the spread of infection, and then talking about which antibiotics are appropriate for those with C. diff infection is important to be discussed with the patient as well as the family members. Here's a very good example as to what a hospital in Florida did. So Florida Hospital, Tampa, located in Tampa, Florida, is a 431-bed tertiary care facility. And they noticed back in January and February 2003, there was a sudden increase in the number of patients with C. diff. And they did a preliminary study, and it revealed that there was cross-contamination of several patients in one room, as well as a room-to-room transmission of patients that had C. diff. And they said to themselves, we have a problem, and they addressed this problem. And they also noticed nationwide that there was a sharp increase in the number of C. difficile infections. They knew that there was a severe risk to the patients, as well as people that were in their facilities, nationwide. They knew that it was difficult to stop this infection occurring. So they wanted to promote a program that would help decrease their rate of C. difficile infections. So we're going to talk about what they did. We're going to discuss if it worked, and what they did, and how they did it, and then what kind of adoption considerations others can use from learning from this case example. So here's a description of what they did. They implemented a comprehensive program to reduce environmental transmission of the bacterium that causes C. diff infection. Contact isolation was implemented for all suspected and confirmed cases. They used bleach cleaning solution. Hand washing with soap and water was promoted. Educational materials were given to patients and visitors. And then they implemented formulary restrictions to prevent overuse of certain antibiotics. So here's, again, the innovative activity in which they did. They used automated reports. They had isolation rounds that occurred. They had prompts for the housekeeping staff to implement proper use of bleach solutions for cleaning. Information for all ancillary staff and physician was given. Information for infection control specialists was used as well. And they gave continuous performance measurement and feedback to everyone involved in the initiative, in this activity. So the question is, did it work? And it looks like it did. They had a 2-year study period, and the hospital's monthly C. diff rate decreased by 66% in February 2003 to December 2004. After that, the rate decreased by additional 55% to a rate of 0.2 cases per 1,000 patient days. So what they estimated was, after they put their plan into effect, in the first year they saved almost $600,000, and they saved $234,000, and then close to $80,000 in the second and third years after the program was implemented. So how they did it exactly was that they formed a task force, and this task force included infection control director, all the practitioners, nurse leaders, nurse directors, physicians, and the environmental service section of the hospital as well. They identified certain objectives, such as they wanted to identify the etiology of the hospital's C. diff cases. They wanted to develop a protocol to prevent the transmission of infection, and overall they wanted to decrease the C. diff infection rate. And they did this by performing some research. And when they did their literature review and they called other hospitals, they found that there wasn't really a comprehensive program in place preventing C. diff infection. But from the review that they did, they were able to gather some important information which helped them become successful. They learned about common modes of transmission, ways to kill the bacterium and the spores, and also the roles of DNA typing as well. They trained the staff. Nurse leaders ran 45-minute training sessions for all employees to have contact with patients. So not only the doctors and nurses, but the cleaning staff and all the other ancillary staff as well. So when we talk about this program that they put into place, it didn't require additional staffing. Staff members were already part of the hospital, and the costs were not high as well. Inexpensive resources that were used were already available at the hospital. Record keeping was integrated into the hospital's electronic record system. And the only expense they really had was they did some DNA testing on those that tested positive, which ran about $100 a patient. So the costs were not high, and the resources used were not great. Again, and the funding came from the hospital's budget. It didn't require anything more than what they were already using for their operations. And they gave out some resources to patients and visitors about C. difficile. This was also available by email from the program developer if needed. And then they discussed adoption considerations within themselves as well as for other hospitals that wanted to get involved in this initiative. But they emphasized collaboration, so it's a team effect. Team members, all need to get involved. Timeliness of the event of the program was stressed, and education and the risk was pointed out to the employees. They promoted publicizing the results, and they didn't want to tolerate any kind of backslide as well. So once the program was in effect, they didn't want to go back to the statistics that they had seen before they implemented their program. After they developed their program, they received a number of inquiries from other hospitals that wanted to put their program into place. So their program worked well, and they were able to decrease their infection rates tremendously. So if people need more information about C. difficile and decreasing C. diff infections, here are some helpful websites and some societies that have plenty of information about C. difficile, its transmission, and its treatment. And these include the Infectious Disease Society of America, the Association for Professionals in Infection Control and Epidemiology, and the Society of Healthcare Epidemiology in America. And that is it. Thank you all for listening, and have a nice day.